Good morning everyone. Today we are going to take a class about stainless steel crowns. As we all know that stainless steel crowns are usually done after pulp therapies, but that is not the only indication or advantage of pulp therapies for stainless steel crowns. There are many other advantages and many other indications of stainless steel crowns. Now let us see that what are the different advantages, indications, contraindications and many other things about stainless steel crowns. So the contents of our topic includes the different types of crowns available, different types of stainless steel crown available, the objectives, like we said, we are also going to discuss about the indications, composition, advantages, disadvantages and the factors to be considered before fabrication of the stainless steel crown, the procedure, how to perform the stainless steel crown, and the tooth preparation, the steps, and these are all the steps. We'll go one by one for each thing. So in the introduction, a stainless steel crown is basically a semi-permanent restoration. It is not a permanent restoration because in primary teeth most commonly we'll be using stainless steel crowns, and as the child becomes an adult, the stainless steel crown will be changed to a permanent zirconia crown or ceramic based crown depending upon their requirement. So stainless steel crown is basically a semi-permanent restoration usually done after pulp therapies in order to protect the tooth from all sides, in order to protect the occlusion, bring back the function and mastication and all these things. So it was first introduced by Humphrey in the year 1950. He called it as chrome steel crown. And most commonly, like we have said, that it is frequently used in deciduous dentition than in permanent. It is used in permanent but in young permanent teeth. So the types of crowns available are zirconia crowns, that is white color crowns, which are more aesthetic and but it will slightly costlier, and the other ones are stainless steel crowns and nickel chromium based crowns. So under stainless steel crowns, what are the different types? In market, how is it available? It is available as 6 types. First one is untrimmed crowns. That means it is completely not trimmed, not contoured. It is just parallel walls that we have to contour it, trim it and fabricate it according to our patient's requirements. First one, untrimmed crowns. Second one is pre-trimmed crowns. That is, they are slightly trimmed and slightly contoured. Next one is pre-contoured crowns. These are better, where their maximum trimmed and maximum contouring has been done in these crowns. There are examples for untrimmed crowns. The example is Rocky Mountain, the company's name. For pre-trimmed crowns, we have Unitech stainless steel crowns in 3M company. Most commonly, we use 3M company ones. And again, 3M company and Unitech stainless steel crowns also provides pre-contoured ones also. So more examples. So what is basically the objective of using a stainless steel crown? It is basically to a crown that is biologically compatible and competent for mastication and clinically acceptable restoration. What these 3 terminologies mean? Biologically compatible means that the alloys or any ions that are used in that fabrication of stainless steel crown should not harm the oral cavity or the system of the body in any way. So that way it should be biologically compatible. It should not create any ulcerations, should not create any disturbance in the system of the normal functioning of the body. Next, it should be competent with mastication. That means while chewing, it should not create any disturbance. And it should be clinically acceptable for restoration. That means aesthetically, visually also, and as well as for function, it should be suitable and comfortable for the patient. Those are the main objectives. That is, the form and function should be ideal. So what is the advantages? Instead of using a stainless steel crown, we can might as well use amalgam restorations or any other restorations. The problem with amalgam restorations is the strength, and once a high mastication force falls on amalgam restorations, it tends to chip off. Therefore, we are using stainless steel crowns, which is a 4-dimension coverage for the tooth, and if there is high mastication force, it can easily take up the force and all the force will be distributed equally, and there is no chance for the tooth to break. That is one of the biggest advantage of stainless steel crown, and it is acceptable both for the parent and the patient, and obviously cost effective compared to zirconia crowns, which are porcelain or ceramic based crowns. Stainless steel crowns are very less in cost, and definitely the parent would afford easily. So the disadvantage, as we all know, we are saying stainless and steel. That means it is black in color. So if the patient opens the mouth, it is visible as something black in the mouth, so it is not very pleasing appearance. Whereas there are these zirconia crowns which are very pleasing in appearance. So the patient would be more looking very like normal, having normal teeth, whereas when he is using a stainless steel crown, it looks like there is something inside the mouth, something has been done. Some patients are considering zirconia crowns, and some patient would consider stainless steel, depending upon their cost and affordability. Otherwise, both are same. So what is the composition? It is nickel chromium based stainless steel alloy. So the composition of nickel, this composition is very important, and you have to remember this. 17 to 19% of chromium is used, 10 to 13% of nickel. We say nickel chromium alloys, but the chromium content is higher, remember this much. 17 to 19% of chromium, 10 to 13% of nickel, 67% of iron, 4% of mineral elements. There is another type of crown, nickel based crowns, where the nickel content is higher, 72% of nickel, 14% of chromium, less content of iron, that is 6 to 10% of iron, then trace amounts of carbon, manganese and silicon. These are the basic understanding that you must have about stainless steel crowns. Now, as we said that we need to know when and where we should use the stainless steel crown. We understood the advantages and disadvantages. Just we have finished it. That is, advantages good function and form. Disadvantages is its only color. Color is the only disadvantage. Otherwise, it is having all good advantages. Now we need to know where we should use stainless steel crown. Like I said, all primary teeth and young permanent teeth, the ones which are having any developmental defects or hypoplastic enamel defects, definitely after pulp therapy. As a preventive restoration, as an abutment in order to restore the fractured teeth, and in cases of bruxism. Bruxism, what happens is the child tends to grind the teeth so badly that there is chances of attrition. In order to avoid attrition of these teeth, a crown has to be placed on the teeth so that when attrition forces are high, there is no chipping off of enamel happening. For that case, we suggest crowns for the patient. So the affordable crowns would be stainless steel crowns in case of younger children. In case of single tooth crossbite also, you can see in the picture how they are using a stainless steel crown in order to correct the crossbite. And this is the disadvantage we are talking about. In case of replacing primary anterior teeth, if we want to use a stainless steel crown, this would be the appearance of the child. That is, the anterior teeth, if this appearance would look like a black teeth, nobody will be having a pleasing appearance. Therefore, for anterior teeth, using of stainless steel crowns is definitely not indicated. It can be used, but it is not indicated just for aesthetic purpose. There is a type of stainless steel crown which you can use, that is called as open faced stainless steel, where the front portion is cut off and a composite buildup is done, or a veneer buildup. Then there will be a support of stainless steel crown back side, that is on the palatal side, and on the front side it is looking like a normal teeth because of white appearance of ceramic or composite. So it is called as open faced stainless steel crown, one of the modification of stainless steel crown. So before choosing stainless steel crown for a patient, what are the factors that we have to consider? The age, primary teeth and young permanent we said is the indication. So the age, whether the patient is going to cooperate for all the steps, will he be able to sit for that long procedure, and is he motivated, is he okay with the procedure, and is there any medically compromised condition that we have to look for before giving nickel based or stainless steel crowns for the child. We have to just have a look at these questions and answer them, and if it is okay, we have to go ahead with the procedure. So not in all cases, but in certain cases where the occlusion is not correct, we have to go for a preoperative occlusion check, where we take an alginate impression of both the jaws and we check the preoperative occlusion on the laboratory itself. So how do we check the size of the crown? We check the mesiodistal width of the existing tooth. The tooth which is there, we have to check the mesiodistal width of it. If suppose it is not there, we have to check on the opposite side. Whichever tooth is there on the opposite side, we can check. That mesiodistal width is the width of the crown we are selecting. We are going to select a crown slightly smaller than the mesiodistal width of the tooth that we are going to replace with the crown. So the tooth preparation involves First of all, you have to well isolate the area that you are going to function on. Isolation is primary requisite of any procedure in dentistry. After isolation, we check for the mesiodistal width and select the smallest crown available. Now, the preparation includes occlusal reduction, proximal reduction, and no buccal and lingual reduction. You have to remember this point: no buccal and no lingual reduction in primary teeth, because the retentive sites, the buccal and lingual surfaces of primary teeth are like this. There is a small cervical retention site on buccal side which will help to entrap the crown so nicely that even while removing during the procedure also we might require an instrument. So we need to use this buccal and lingual retention sites as it is. Therefore, we are never going to trim on the buccal or the lingual side. And most importantly, on the proximal sides, what we are going to do, we will see. So occlusal reduction is like this. From this side to this side, we can observe the occlusal reduction based on the adjacent teeth or after biting. We ask the patient to bite, and then we should be able to see a small gap of at least 0.5 to 1 mm or 1 to 2 mm with the requirement. When we are able to see that clearance, that means we have made a proper occlusal reduction. If you are not able to assess like that, then we can see the adjacent tooth. If it is the occlusal surface of the tooth that we have done reduction is slightly lesser, means we have done proper reduction. This is occlusal reduction. We have to do by following the cuspal angulations. If the cusp is like this, then our reduction also should follow the same contour and the same shape. We cannot make a flat surface. Making a flat surface will create more stress bearing areas and the tooth will eventually break if the forces of mastication are higher. So this is what I was talking about, the clearance. When you bite, this is how you should be able to see. And if you are not able to see like that, compare it with other adjacent teeth and see. Next is proximal reduction. Proximal reduction for permanent teeth requires finish lines. That is chamfer or shoulder finish lines. But in primary teeth, no finish line. If you create a finish line, you are creating a ledge. So we do not create any finish lines. There is very minimal degree taper and it should be a proximal reduction of 0.5 to 1 mm, proximal reduction on either sides. Buccolingual reduction, minimal or nil. And then you round off all the line angles. And then we go for the next step of adapting the crown. We have already selected a crown. Now we have to place it on the reduction and check for snap fit. Snap fit is we have to place the crown on the lingual side and just push it to buccal side. When you push it, it will go and engage under the cervical constriction area and a small click sound would be heard. If that click sound is heard, that means we achieved the snap fit. That is initial adaptation of crown. Now what will you see and what will you check after placing the crown in the mouth? Two things, two important things. First one is blanching. After placing of the tooth, the crown, is there any blanching on the gingiva, on the gums? If any whitish appearance is seen, that means we placed it way too much inside the gum and the gums are affected because of the crown's length. So we have to reduce the length of the crown, height. Next is after placing the crown, is the patient able to chew? Is the mastication or the occlusion the same as before? It would not be, because the length of the crown is already high. So we have to start reducing it. So there is procedures after reducing the height. We reduce the height so much so that the patient should be able to bite exactly like he did without the crown. Without the crown, his normal occlusion. After placing the crown, his occlusion should be the same. There should not be any hindrance. There should not be any occlusal interferences for the patient. After that, we start shaping the crown. That is called as contouring. We create a bell shape effect on both buccal and lingual sides using this contouring plier. Here it is having a convex surface. Here it is having a concave surface. So after cutting off the crowns, bringing it to a correct length, we do the contouring, which brings a proper shape to the crown. Because we were using what crowns? Untrimmed, pre-trimmed and pre-contoured crowns. We have already seen the types of crowns. That means they are not fully in the correct shape to the fitting of the patient. So they are just pre-trimmed. Final trimming we only have to do, and pre-contouring they are only pre-contoured. Final contouring we only have to do. So this is the plier that we use to contour it, bring it to a proper contoured shape. Similarly, crimping is where the gingival 1/3 of the crown we have to bend it inside so that more retention is available. More retention of the crown can be achieved. For that we use this plier, which is called as crimping plier. Only this much part of the portion is what is the crimping section of the plier. So only gingival 1/3 of the crown only will be pushed inside to adapt to the tooth, and this adaptation will create more of retention. And by doing this crimping, what we are doing is we are pushing the crown inwards towards the tooth, so the gingiva is supported. The gingiva will be safe, and any time the occlusion forces are higher, the sharp edges of the crown will not affect the gingiva. There will be no bleeding eventually anytime in the future. Finally, we check for the adaptation, we check for blanching, we check for the height, we check for comfort in biting, and any other hindrances anywhere else, and we check for final adaptation of crown. This is what is checking for final adaptation. If we are okay with this, we have to take a radiograph. Why radiograph? We have to take a bite-wing radiograph because we don't know how far radiographically the extent of the crown is. Just to confirm that your final adaptation is correct, we take a radiograph. And then our favorite procedure, cementation. You use type 1 luting GIC or any other luting cement to fix the crown to the tooth. While using this luting cement, we use, in case of GIC, we use it in 1:1 ratio. The powder liquid ratio should be 1:1, and after mixing, only half of the crown should be filled with the cement. We cannot overfill it because after placing onto the tooth surface, extra cement would leak out, and if it is not removed within time, then it will stick and it will become very clumsy. So only half of the crown should be filled with the cement, and immediate placement should be done, and whatever excess cement is there should be removed immediately at the same time, either with the help of a probe or with the help of a floss. So other cements that can be used are zinc phosphate, polycarboxylate. Most commonly used is GIC type 1. And then we ask the patient to close tightly and wait for 2 minutes. The excess should be removed. This is how the excess is to be removed: interdentally using a floss, and gingivally using an explorer or a probe. This is the final result. Confirm the occlusion once again, and if in case any modifications are required, before only we can do. This is just for your understanding. In case we have a oversized tooth and our crown is very small, then we can add a small band of stainless steel band and solder it to the available smallest crown size. And if we have a small crown and the tooth, our tooth is very small and the crown that we have is very big, and we want to use the same crown, means we can do a small V-shaped cut on the crown and solder it back. So that way we can use a oversized crown for a small tooth, and we can use a small crown for an oversized tooth as well. These modifications can be done. So the most common complications or that can happen while using stainless steel crowns is, if the fit is not proper, the margins will be poor, and sometimes the crown may get tilted if it is not correctly adapted during cementation. And in case the cementation is poor and there is a saliva contamination during cementation, there is chance of loosening of crown and inhalation, and ledge formation if the proximal cutting is incorrect. Those things can happen. So you can refer to textbooks like Kennedy and Shobha Tandon or Nikhil Marva for your understanding and learning. Thank you.